Okay. Good afternoon, everyone. Welcome to our 2023 Grand Rounds. Happy New Year to everyone. And we are very happy to start the new year with one of our own faculty, Malika Rawal, who joined us here in 2019 and finished her fellowship here in 2021, joined us, and has been very active in clinical and education fields, and has developed a great interest and expertise in management of transgender individuals, their medical problems. And today she's going to talk to us about gender-affirming hormone therapy in adult patients. So welcome to all, and go ahead.
Well, thank you, Dr. Mokshigandam, and Happy New Year, everyone. Today, as mentioned, I'm going to talk about gender-affirming hormone therapy in adult patients, and you'll see that that's abbreviated throughout this presentation as GAHT. And I'm so happy to talk about this. It is something that has become near and dear to me in the practice of endocrinology, and so I hope that you all are able to enjoy it. So some disclosures. Regarding this talk, I have no conflict of interest, but I do understand that transgender medicine is still a controversial topic. To many people, it may not align with their beliefs, and so if it's something that you're uncomfortable with and you're approached about, I do ask that you refer to another endocrinologist, because there are many of us that are very happy to perform this area of endocrinology. Also, I'm only going to talk about gender-affirming hormone therapy for adult patients, and as that is my area of practice, and I won't be able to comment on providing GAHT to intersex individuals, though that is another area of endocrinology. It's important to know that providing hormone therapy for transgender patients is not restricted to endocrinology alone. Additionally, there are many different protocols or provider-specific preferences to guide prescribing gender-affirming hormone therapy. So I'm going to talk about the things that I've been taught and that I also have found to benefit my patients and work well. And then it's important to be aware of your state laws, because gender-affirming hormone therapy is not currently FDA approved, and some states have different legislature regarding care of transgender individuals. I've included this link that basically shows a map of the United States and the different areas and their policies regarding prescribing gender-affirming hormone therapy. So a special thanks, and I didn't warn them ahead of time, but special thanks to Dr. Louisville Folsom, who first introduced me to the practice of gender-affirming hormone therapy, and really piqued my interest in it, and taught me a lot about how to provide good care to these patients. So objectives today: first, I want to define gender-affirming hormone therapy and its use in the setting of gender dysphoria. I want to talk about the current strategies used to prescribe gender-affirming hormone therapy, and then go over some specific guidelines. So a little perspective. So I found this interesting statistic that a big improvement was noted in how many Fortune 500 companies actually included gender identity in their non-discrimination policies. It used to be less than 50%, but by 2022, it had risen to 91%. But only 66% of those companies offered transgender or gender diverse, abbreviated as TGD, inclusive insurance coverage, and only 72% of those companies provide any form of education or cultural knowledge training to their employees regarding LGBTQ care. And that was noted in the Human Rights Campaign Foundation study from 2022. So my goal is, by providing this lecture, those of us who already don't practice transgender hormone therapy prescriptions can be more aware of it, and then we can kind of use it as impetus to train our office staff about how to be sensitive to this particular patient population. So here's that map of the United States showing current policies. And we can see that Kentucky is this light kind of green color, which means there's no real laws in either direction that either protect transgender individuals or prohibit transgender inclusive care. There's only one state, which is the orange state, which actually permits insurers to refuse care based on a patient's gender identity. And the starred states are places where there is protection specifically for these individuals. Hopefully we'll see a star in Kentucky soon. So just some background again, there are different types of transition when talking about transgender care. First is social transition, and that's when transgender individuals present oneself in public in a way that aligns with their gender identity. There's also legal transition, which involves legally changing their gender and their name via the court and government system. And if your patients ever want more information on how to do this, I recommend that they visit the site transkentucky.com because it provides a step-by-step on how to get this done. And then medical transition. So this is the use of hormones or hormonal blockade or surgery to achieve a physiology and body structure that aligns with one's gender identity. And this will be the focus of our discussion today. So some definitions. So Dr. Folsom, this should look familiar to you. So she introduced us as fellows to the gender-bred person. And so this helps to kind of frame the different terminology when we talk about transgender medicine and gender-affirming care. So a person's gender expression is what they see on the outside. It's that gender-bred person's icing and buttons and how they look outside and how that relates to cultural-related gender stereotypes. Their actual gender identity is how they feel they are in their brain. What do they think their gender is along the spectrum? And then orientation or sexual orientation is who is in their heart, who are they attracted to? And that can be unrelated to their gender identity. So gender identity does not determine sexuality in such a way. And then sex, biologic sex, is how you were born and your chromosomes, body parts, genitalia. The biologic sex then is whether one is born as female based on chromosomes and genitalia, male or intersex, or somewhere in between. This is an objectively measurable term. And so, a female biologic sex would be consistent with ovaries, vagina, uterus, estradiol production as the sex hormone, and XX chromosomes. Intersex would be something in between, and male would be the presence of testicles, penis, testosterone, and XY chromosomes. Gender identity, however, also has two sides to it and is a spectrum, and it's the gender or lack thereof with which someone feels most aligned. So when their gender identity doesn't align with their actual biologic sex, they're called transgender or gender diverse, abbreviated as TGD. When their gender identity causes distress to the patient and alters their ability to function and causes negative consequences, that's when we use the term gender dysphoria. So someone may have a gender identity which doesn't align with their biologic sex, but they do not necessarily have gender dysphoria unless it causes them distress. And not every person with a transgendered identity chooses to undergo medical gender-affirming care or surgical reassignment. Gender expression is how that person outwardly expresses their gender. And this is going to be different amongst different cultures because every culture has different ideas of what it means to be masculine, feminine, in between. And so it really can differ, and it also is a spectrum. And then sexual orientation, again, is who they're attracted to. So some other terminology to use. One thing that our patients will talk about a lot is their dead name. So when they choose to begin their transition socially, medically, they may choose a preferred name that is not the name they were born with. And they may choose a name that aligns more with their gender identity. And so we should use their birth name from that point forward as a dead name, and we should not mention it any further. We should use the name that they choose. And then it's important to ask about pronouns and how their gender identity should be acknowledged in pronouns. I myself use feminine pronouns, she, her, and hers, but They may also use he, him, his, they, them, theirs. And then there are several transgender identities or terms to refer to them. For example, a transgendered man may be referred to as female to male, FTM, or AFAB, as assigned female at birth. Similarly, with a transgender woman who may be described as male to female, MTF or AMAB. A non-binary person who doesn't necessarily align with either of those other two gender identities can be described as non-binary or gender diverse or gender fluid, gender creative, gender expansive, and a term that we no longer use is gender non-conforming because of its negative connotation. Things we should not say when referring to transgendered patients. We no longer use the terminology gender identity disorder, and it has not been included in DSM earlier than DSM-4. Transsexual is not a term we should use, nor tranny, nor transvestite to refer to these patients. So we were recently blessed with new guidelines from WPATH, which we'll talk about more, but basically they recommend that all healthcare professionals should use culturally relevant language when applying standards of care to these patients. So while here in America we may have certain culturally appropriate terms to describe transgendered patients, these can differ from country to country and community to community. So I'll stick to the ones that are more common in practice in the United States and North America. They also recommend that we use language in healthcare settings that upholds the principles of safety, dignity, and respect, which is why I mentioned those terms that we should try to avoid using when caring for these patients. Whenever possible, if these terms are used in a patient's medical chart, we should try to remove them and update their chart appropriately. And finally, it's recommended that healthcare professionals discuss with each patient individually how they wish to proceed. So what's right for one is not necessarily right for all. So using sensitivity and asking them how they'd like to be addressed, their pronouns, and how they like to be referred to. Okay. So who should we prescribe gender-affirming care for? So the criteria to provide gender-affirming hormone therapy for adults includes a persistent, well-documented gender dysphoria or gender incongruence, the ability to make an informed decision and to consent for treatment, as with any medical care, and mental health concerns that must be reasonably well controlled, independent of gender dysphoria. The goals of gender-affirming hormone therapy are multi. So first we should talk about what the patient's goals are. And this is a discussion to have with any patient at their initial visit. Not every patient is going to want the same things. So never make assumptions is something I've learned, and ask as many questions. They're usually more than happy to talk about it. Okay, so first questions I like to ask are, what is it that you're hoping for with medical transition? What would you like to see change physically? How do you think this will help you change emotionally, sexually? At the end of this journey, what is it that you hope has changed? Who is the person you hope to be at the end of this? And what do you hope stays the same throughout this transition? What do you hope will not change? And which aspects of your biologic sex cause the most significant dysphoria? What are the triggers for your dysphoria? Because that's going to prioritize our hormone therapy and our referrals, etc. And then physician goals. So firstly, of course, we want to provide a safe and respectful environment. We want to, through the use of gender-affirming hormone therapy, reduce their endogenous sex hormone levels and replace it with sex hormones which affirm their identity. We want to manage their expectations, and this is going to be a big one. We, of course, want to minimize complications and figure out which comorbid medical conditions they have and how to control them. We want to provide referrals to other practitioners as needed as well. And so referrals can commonly include several places. So in some patients, we provide referrals for gender-affirming speech and voice therapy. We can provide referrals for gender-affirming surgeons, mental health services, reproductive endocrinology if they wish to preserve their fertility before this process, and hair removal centers. So this is something that I also learned from Dr. Folsom, amongst many other things, is that it's important to really talk to the patient about what to expect. And a lot of my transgender patients, I've been blessed that they've come in with a lot of self-research and motivation, and they are able to tell me more than I even know about this. But they've been waiting to do this for a period of time and to be who they truly are. And so there's some small sense of impatience. And so it's important to kind of let them know that nothing's going to happen for a while. We're going to start hormone therapy, and physically things may not change. And so you're going to notice nothing, and then you're going to see me after 3 months, and you're going to notice more nothing, and then, so on and so forth. And so letting them know the expected timeline for their physical changes is very important to help with satisfaction and to help with their confidence and esteem and mental health. The peak physical effects for gender-affirming hormone therapy usually occur after 2 to 3 years of therapeutic levels. So it is a waiting game, and it's just like puberty. It's long and awkward, and at the end of it, it turns out okay. It's important to talk to them about what changes are reversible and which changes cannot be reversed after starting gender-affirming hormone therapy. Additionally, kind of laying the groundwork to let them know how often you should expect to meet. The recommendations from WPATH are to meet every 3 months for the first year, and thereafter you can space your visits to every 6 to 12 months if their hormone levels are therapeutic and their complications are managed. Additionally, it's important to have a discussion about what role mental health services will play in their transition. It is not a requirement in the state of Kentucky that a patient have a mental health professional diagnose gender dysphoria before starting hormone therapy. That being said, it is going through puberty again. It is something that can cause distress and dysphoria. And me personally, I feel as though I'm getting my grasp of the medical part, but the psychological part is something I haven't practiced in some time. So I often recommend that they do have a mental health provider on board that they can reach out to should their mood change, should they have any questions or complications, and to help them further explore their gender identity, their sexual orientation as appropriate. And then most importantly, in my opinion, is talking about fertility, because not in every case, but in a lot of cases, once you start gender-affirming hormone therapy, if they wish to have a biologic family in the future, it's going to be very difficult and require a cessation of this hormone therapy, which can then, lead to further dysphoria and other complications. So I do like to talk about whether they have plans to expand their family before prescribing hormone therapy and then provide referrals as needed. A lot of times there is some cost that is prohibitive in fertility preservation, especially in trans men, but it's something that we should always present to them and tell them how to go about finding out about cost if they are interested. Okay, so where do we go to and who do we turn to for guidelines on how to do this? And so there are two major bodies that I have used in my practice and that I think have clear guidelines. That includes the Endocrine Society, and they have a guideline entitled Endocrine Treatment of Gender Dysphoric or Gender Incongruent Persons, and also the World Professional Association for Transgender Health, which is the WPATH, and they just released their 8th version of their standards of care in 2022. So feminizing hormone therapy. In a patient that is wishing to undergo feminizing hormone therapy, we have a couple of goals. With estrogen, we're able to suppress their endogenous hormone levels and replace it with the feminizing hormone, which fits with their gender identity. Our goal is that their serum estrogen levels should fall between 100 and 200 picograms per milliliter, and that their serum testosterone levels should be suppressed at least less than 50 nanograms per deciliter. Estrogen can come in several formulations. There is an oral version, which usually we recommend they dissolve under their tongue for maximum absorption. It can also be transdermal, and it can also be parenteral. The choice of formulation is really patient-specific and also has to do with what the cost is relating to insurance. A lot of these medications are, like I said earlier, off-label, and so may have different costs for every patient, depending on their insurance. And then the other part of feminizing therapy is to block androgens and to block those secondary androgenic features. And so this is not going to affect their endogenous hormone levels, but will change their physical appearance, and in a lot of patients, their well-being, because a lot of the androgenic features are what are their triggers for their dysphoria. So our goal with the androgen blockade is to decrease the severity of facial and body acne, to slow hair growth, and decrease the risk of male pattern baldness and scalp hair loss. And so formulations for androgen blockade that are currently used most commonly are spironolactone, bicalutamide, and in places other than the United States, they also use cyproterone. There are some special circumstances I wanted to bring to light that are in the most recent WPATH guidelines, and that is that we should not use ethinyl estradiol any longer for use in gender-affirming hormone therapy, and this is mainly because of the venous thromboembolism risk and PE risk. They also recommend that transdermal estradiol should be the preferred treatment in patients that do have an increased risk of VTE, or if they have a history of prior VTE, especially if their age is more than 45 years. And then they also recommend that we do not use conjugated estrogens if more safe options are available. And lastly, they do recommend that we use androgen blockade whenever possible in patients that are undergoing feminizing therapy. So these are some example regimens of feminizing therapy. And so an oral start dose would be about 1 milligram sublingual every day, and the maximum tolerated daily dose would be 6 milligrams per day. And you would increase this slowly over a period of time. Usually at every 3-month visit, you'll assess levels, assess for complications of estrogen therapy, and decide whether a dose increase is appropriate based on a patient's own goals and if they still have a lot of dysphoric triggers. An IM start dose would be either 10 milligrams of estradiol valerate every 2 weeks or 10 milligrams of estradiol cypionate every 7 days. Transdermal patches come in 0.1 milligrams per patch, and you put 1 patch on per week with a maximum dose of 0.4 microgram patch twice a week. Spironolactone is the most commonly used androgen blockade, and a good starting dose is 50 milligrams once a day, or you can actually split it 25 milligrams twice a day if they're having orthostatic symptoms or they already have a low to normal blood pressure. A lot of times I do mention to patients if they're splitting their dose to take it with breakfast and lunch rather than actually morning and night because of the diuretic effects. You don't want them to be up all night running to the bathroom because then they won't like you very much. So I usually tell them to take it earlier in the day. And the maximum dose of spironolactone is 400 milligrams a day. So now we talk about progesterone, which is, not my favorite thing to talk about, but something to be well informed about because it's brought up often. And so in the most common guidelines, WPATH states that it is common knowledge that some practitioners prescribe progesterone in feminizing therapy. And, there's a lot of social media information and small anecdotal kind of studies or animal studies that cite that use of progesterone can improve breast development, areolar development, mood, libido, overall well-being in transgender women. But they did say that these benefits are anecdotal. There's no high-quality evidence to support use of progesterone as a standard of care in feminizing therapy. And actually what they found is that most of the systematic reviews have actually documented existing harm of progesterone use with extended exposure. Some of the potential side effects of progesterone include weight gain, worsening of depression, and unwanted changes to the lipid profile, specifically low HDL, which can alter their cardiovascular risk. So it's important to have a good discussion with your patient about the use of progesterone. My own practice is that I usually suggest that we see what kind of physical effects happen after 1 year of therapy or therapeutic on therapy, because we know the peak increase in breast size is going to happen at 2 years. So after 1 year, if there's not some beginning of growth, then we can revisit the topic. But of course, it's ultimately the patient's decision on whether or not to accept the risk of progesterone therapy. Some of the physical changes we should expect to see with feminizing therapy include breast growth, tenderness and discharge around the nipple site, decreased spontaneous erections and overall erectile function, decrease in testicular size, increased body fat percentage, so more of a gynoid shape rather than android, and decreased lean muscle mass. And these changes have different onset and different peak. And so, as said earlier, really until 3-6 months, a lot of these things don't even begin to occur. The most common things that patients have reported to me at the 3-month visit is decrease in spontaneous erections and some softening of their skin. But the peak of most of these changes is going to happen after at least 1 to 2 years, and maximum around 3. Now we move on to masculinizing hormone therapy, which is the use of testosterone to achieve serum testosterone levels similar to that of a cis male. And so we're looking for testosterone levels to be between 400 and 700 nanograms per deciliter. Similarly, testosterone comes in different formulations, so we can do an IM or subcutaneous formulation, which is dosed every 7 to 14 days. We can do a gel or a patch, dosed daily or weekly, or there's also an oral form, which the brand name is Tilando, and it's dosed twice a day. And then to kind of go opposite of what we just talked about, in transgender men, we can use progesterone or IUDs to help reduce menstrual bleeding if this is a dysphoric trigger. Physical effects of testosterone include deepening of the voice, clitoral enlargement or bottom growth as referred to by patients, growth of facial and body hair, cessation of menses, atrophy of breast tissue and decreased chest size, decreased body fat percentage, but more distribution in the abdominal area, and increased lean muscle mass and increased endurance. Again, they have different onset and different peak effect. And it's important to really talk about those that are reversible versus not, especially with testosterone therapy. So the changes that are less commonly reversible include changes in skin texture and oiliness. You're not going to have reversal of facial and body hair growth. Once there's a hormonal male follicle, it usually stays. Clitoral enlargement usually is not reversible, and deepening of the voice is usually not reversible. Common side effects of hormone therapy. So this is a discussion that also needs to be discussed with a patient at the first visit and reminded thereof, and we will monitor for these possible complications throughout all the visits. Feminizing hormone therapy carries a risk of increased venous thromboembolic disease with use of estrogen, alterations in liver enzymes, hypertriglyceridemia, and hyperprolactinemia or prolactinoma, unmasking of a prolactinoma. Things that might possibly be increased would be risk of type 2 diabetes with presence of additional risk factors, and there's no conclusive evidence about increased risk of breast cancer with estrogen therapy. To monitor feminizing therapy, keeping these risks in mind, we should try to get baseline and periodic levels of liver function enzymes, cholesterol levels, a prolactin level at baseline and at the first couple visits to note if there's any increase with increasing estrogen levels, an estradiol and testosterone, and possibly basic metabolic panel if on spironolactone. We want to do a thorough family and personal history of coronary artery disease, any thromboembolic events, if they have any hypercoagulable states that run in the family, or a family history of liver disease. And it's important to minimize their VTE and PE risk, to really discuss tobacco cessation and abstinence, and also to prescribe pharmacotherapy if needed to help them to overcome their tobacco use. Other effects of hormone therapy that patients have reported to me include nipple discharge, which we do expect, and urinary incontinence, which is believed to be due to softening of the periurethral muscles and everything like that, and a little bit of loosening of the prostate, so there is some urinary incontinence. Usually that improves by doing some Kegel exercises to strengthen. And then this is a study that Dr. Krishnasamy forwarded to me about the utility of monitoring potassium in our transgender patients on spironolactone. And in this study, what they found is that hyperkalemia was quite rare In 310 patients that they studied, only 8 developed hyperkalemia. And they noticed that that was about 2.5% of their patients. And it was dose dependent. So majority of the patients that developed hyperkalemia had a dose of spironolactone that on average was about 178 milligrams per day versus 91 milligrams per day in those that did not develop it. And then it happened more frequently if they were of increased age and maybe had other reasons to have reduced renal function. And so the cutoff that they put there is age 45 years. And so it's suggested based on this study that maybe we don't have to monitor potassium quite as often in our patients on spironolactone if they are less than 45 years of age and on a lower dose of spironolactone, because it seems to be less likely. Risks associated with masculinizing therapy that are very common include polycythemia and sleep apnea. Things that are possibly increased include liver enzymes and a worsening of your lipid panel with increased cardiovascular risk. And then with testosterone therapy, there is some associated change in mental health, and a lot of patients do report increased aggression, but usually it's manageable. What I found helpful is if patients have significant fluctuations in their mood on injectable testosterone therapy, if my baseline is starting at every 14 days, I usually recommend we decrease the interval to every 7 days or every 10 days and alter the dose accordingly so there's less of a peak and a trough. And then, of course, regular follow-up with their mental health professional. To monitor masculinizing therapy, it's important that we keep track of our liver enzymes, our cholesterol, our hematocrit to monitor for any polycythemia, and of course estradiol and testosterone levels to monitor our dose and to titrate as needed. It's also important to consider a sleep medicine referral if there's a pretty high pretest probability of sleep apnea, because testosterone therapy can certainly worsen it and aggravate any fatigue, weight gain, hypertension, and lead to catastrophic consequences such as arrhythmia. And then another thing I found when preparing for this presentation is whether or not baby aspirin will play a role in mitigating the polycythemia that happens if it does. And there really wasn't any clear role. The recommendation right now by Endocrine Society is that if a patient does develop erythrocytosis with a hematocrit greater than 54%, I believe, is to suggest a phlebotomy or to alter the dose of their testosterone therapy. Okay, so now that we've gone over the basics, some other things to consider when providing gender-affirming hormone therapy. So as well said by Dr. Folsom during my fellowship, if the body part that you have can get cancer, it should continue to be screened. And so I think this is good advice. And keeping in mind what surgeries a patient has had throughout their transition and advising them to keep up to date on their age-appropriate cancer screening. A lot of times my trans men have less anxiety about going for their cancer screening if they take a female friend or partner with them, and that way it seems as though the appointment is for that cis female friend. So that's one suggestion that I can put out there. And then keeping on top of their mental health. So the most recent WPATH guidelines, again, kind of guide us on this. And so they do recommend that patients that are undergoing gender-affirming hormone therapy have a mental health professional to touch base with. Again, it's not a requirement for hormone therapy, but strongly recommended. And then importantly, they also say that we should continue their existing hormone therapy, even if they have deterioration in their mental health, but we should then, kind of assess why they had a deterioration in their mental health and work in a multidisciplinary fashion to stabilize them. Additionally, we should consider their bone health. And so there has been conflicting data about the risk of osteopenia and osteoporosis in transgendered individuals. And I think a large part of why there's a lack of data is because there are not a lot of patients over the age of 50 that have been studied to be included in long-term studies. But one study that I did found was done in 2019, done by Stevenson and Tang Precha, and basically they tried to piece together some recommendations right now of how to monitor bone health in our general population and applied it to transgendered persons. And so they've pieced together recommendations from the American Association of Clinical Endocrinology, from risk factors that we use on the FRAX calculator, from Endocrine Society guidelines, and come up with this algorithm, which basically says that if they have any known risk factors, such as an increased age, family history, steroid use, arthritis, gonadectomy in the past, so any gender-affirming bottom surgery, a low body weight, etc., then we should get a DEXA and screen them. And depending on that, we should treat them just as we would a cisgendered person who had low bone mineral density, osteopenia, or osteoporosis. As far as complications of hormone therapy in transgendered individuals, there was one study that looked over 5 decades of gender-affirming care in Amsterdam and tried to piece together if the things that we initially were worried about when we started gender-affirming hormone therapy were still true. And so they looked at a large population of transgender women, 317 patients, and of transgender men, there were less, only 44. And looking at their mortality ratios, what they found is transgender women, when compared with cis men, had an increased risk of mortality overall, over all 5 decades. But strikingly, when compared to cis women, their increased risk for mortality was 2 to 3 to 4-fold, right? So much more increased. And that continued over the decades and reached 5.2 times by the period of 2010 to 2018. And this is not breaking it down by cause of mortality. When they looked at transgendered men, they did find that they did have also increased mortality compared to cis women and cis men. So this is something that needed to be investigated further. What they found when they looked at cause-specific mortality is in transgender women, they found a cause-specific increase in cardiovascular disease, almost 2.6 to 3-fold compared to cis women. When they looked at infection rates, the numbers are quite shocking, and they found that other infections and HIV infections had up to an 8.7 to 47 time increased odds compared to cis women. And similarly, even an increased odds ratio compared to cis men. And the most important to me is suicide. So we can see that this is something that is a place that we can intervene and is modifiable, in my opinion. And the suicide odds ratio was increased compared to both cis men and cis women when looking at these transgender women. In transgender men, there also was an increased risk of cardiovascular disease compared to cis women, but no significant increase compared to cis men. Actually, slightly decreased odds ratio of cardiovascular disease. When it came to infection, they didn't have data, but compared to cis women, transgendered men had up to 4-fold increase in non-natural cause deaths and up to 2.8 times increased risk for suicide. Right, so I finished a little bit early, I think, but I hope you guys enjoyed the presentation, and I'm open to any questions.
I have a question. Johanna Archer in Norfolk, Virginia. So menopausal hormone therapy has been shown to decrease cardiovascular disease and diabetes in women. But, and I have to admit, I missed the beginning of your talk. I'm sorry, I was seeing a patient. But you described having higher incidence of cardiovascular disease and diabetes when you take feminizing hormones. Is that, I'm getting that right?
So, yes, transgendered women who take estrogen as part of their feminizing care do have increased risk of cardiovascular disease in that, 5-decade study that we talked about, but also in other smaller studies. And I think that...
Yeah, why do you think that is true? Yeah.
So I think it has to do with the incidence of cardiovascular disease based on their biologic sex to begin with, but also in adding estrogen therapy, there can be alterations in their lipid profile that are not favorable. I think these things, I can't be that precise about it. I apologize, but one protective thing, in my opinion, is the change in adiposity. With feminizing therapy, there should be less, visceral fat deposition and more subcutaneous fat distribution once you have that effect. So maybe over time that will be mitigated, but so far the studies have shown increased cardiovascular risk with use of estrogen.
Because mostly they do oral estrogen rather than transdermal, correct?
So lately, though, a lot of patients have been requesting injectable therapy over oral. And I think it has to do with, remembering to take it every day. So they want to know that their hormone levels are good. And if they miss a dose or anything, there's a sense of guilt or a sense of losing traction towards their goal. And so injection seems to be a pretty favorable option in their mind to make sure they're getting their dose. So I have increased my prescriptions for injectable over oral.
Are there any good studies?
Yeah. Yeah, so apart from the Dr. Mokshikandam's question was, if there's any long-term studies about complications and outcomes of gender-affirming hormone therapy in either transgender men or women. And other than the study that I presented, I didn't find any large studies that looked over a long period of time. Specifically, are you talking about complications or mortality outcomes? Yeah, the one that I presented was really the only one that I saw. Yeah.
Because, the formulation.
Yeah. So Dr. Mokshigandam's point was that our formulations and our goals of therapy have changed significantly over the past 10 years, which I think is a great point. What has been documented in a lot of smaller studies is a decrease in, what we thought was the risk of VTE and PE with the different formulations of estrogen. And that's why I think in the most recent WPATH guidelines, they made clear not to use conjugated estrogens, ethinyl, estradiol, if at all possible, because those are really what were contributing to that cardiovascular risk. Yeah, Rawal.
Transgender without the dysphoria. Are there like ICD?
So Dr. Pansari, his question was if there's any ICD code to distinguish between a transgendered person and a patient with gender dysphoria. And yes, I don't know that there would be instances in endocrinology where we would use the ICD-10 code specifically for transgender. Usually, if I'm providing hormone therapy, I would be documenting their gender dysphoria, and I would also be documenting hormone replacement therapy or hormone monitoring as reasons for our visit. A good question.
But individual so it's a younger individual with a history of family history of breast cancer. And is there any recommended test for BRCA mutations? Because potentially then you could have them undergo bilateral test tissue removal.
Right. So the next question was if you have a young patient who wants to undergo feminizing hormone therapy, but there's a strong family history of breast cancer, what recommendations are there for screening or workup prior to starting hormone therapy? And so really, based on the studies being conflicting about whether or not estrogen therapy in transgendered patients actually leads to increased risk of breast cancer, I think I would treat it like anyone that has a family history of BRCA or breast cancer. And I would use the guidelines that are there already to guide me on who should get a mammogram. So I apologize, I'm fuzzy on what that is after taking my medicine boards. But I think it's start mammogram at 30 if they have a family history, right? And work up genetic testing for the same indications. Dr. Folsom, I'm sorry to put you on the spot, but Do you know if there are any other recommendations for who to screen for breast cancer?
What I know is that anybody with breasts is at about a 1 in 8 chance of having a diagnosis of breast cancer throughout their lifetime. And you're exactly right. For somebody who has a first or second degree relative with a history of breast cancer, insurance will cover a mammogram, a one-time test at age 35, and then it's recommended to screen yearly for sure at 40. So that's the overall recommendations for breast cancer. I don't believe there's anything specific for transgender women compared to cisgender women, since breasts are breasts, no matter when you grew them.
And the same would apply for transgendered men who haven't had gender-affirming surgery, I would think.
Correct, yeah. As long as you have the body part still in place, then it's recommended to screen for cancer, just like you so beautifully stated in your presentation.
Any other questions?
Well, hi, Dr. Winters here, Malika. That was very informative, and I think you pointed out very nicely how one needs to be a comprehensive doctor to take care of these patients. That it's really much more than just endocrinology that you're being asked to do, and so you're taking on a big responsibility when you take care of these patients. So one thing about the injectable estradiol, and so just like anabolic steroid abuse in men, injectable estrogens have a potential for abuse in transgender women. So how do you deal with that?
Gosh, so I think that ultimately I'm there, and my duty to that patient is to provide their gender-affirming care. And so I feel that if I have satisfied myself that this patient meets the criteria of gender dysphoria, whether it was diagnosed by a mental health professional or by our conversation and other clues, and as long as I'm prescribing this hormone therapy in a fashion that is minimizing complications, is staying within the therapeutic goal, then I think that's the most I can do. I think playing detective sometimes and trying to look for, there may be ulterior motives or reasons for abuse, just with testosterone and cis men who are hypogonad or not hypogonad and want to build muscle, like you said. I think that it's hard for us to play detective, but our lab clues will kind of indicate if their estrogen stays within that goal range for transgender women, then I'm still within my practicing guidelines. If I'm still making sure there aren't complications, I'm still within my guidelines. I think one thing that was a stumbling block for me initially was that I did not manage what kind of visits we would have, and I didn't set that timeline with a lot of patients. With estrogen therapy, it's less, in my mind, less crucial because it's not a controlled substance, although it can be abused, as you said. But with testosterone therapy, particularly because it's controlled, there need to be periodic visits to continue prescriptions. And so that's why I kind of included that, because letting them know when they should expect to see you and how often they're going to be getting blood work is important for continuing therapy and monitoring for any abuse, in my opinion.
Thank you. For two other medications, what is the status of GnRH analogs in these patients? And you mentioned that high dose spironolactone was associated with hyperkalemia. How do you monitor how much spironolactone you should be giving?
Yeah, great question. So I do think GnRH agonists have a role in transgender care and transgender women, but more so in the prepubertal adolescent phase. And so it's not, as far as I know, typically part of providing gender-affirming hormone therapy in adult trans women. So I didn't mention much of that, but I think it is used more in adolescent care. And then how to monitor spironolactone. So, of course, making sure they have appropriate renal function to clear. I often ask them about orthostatic symptoms to make sure they're not having those kind of symptoms, and that would kind of prompt me to reduce their dose. But really it has to do with those physical characteristics. So every visit I'm asking them, how often are you removing hair? Does this make you happy? Does this make you mad? Is this an improvement? Is this the same? And a lot of times they'll tell me that even though they still have to remove hair from their face almost every day to get a clean look, they're still quite happy because their arm hair hasn't grown back in 10 days, or every 10 days they have to remove it. So I guide it based on their satisfaction with those physical characteristics.
Thank you.
Yeah. Yeah, so Dr. Krishnasamy mentioned that in her experience at the VA, because they're providing gender-affirming orchiectomies in trans women, those patients have significant swings in mood and triggers of gender dysphoria because of the rapid drop in testosterone levels, and how to kind of mitigate that. And I've actually seen the reverse. I've seen my trans men patients that have had gonadectomy have not only symptoms of menopause and everything, but significant dysphoria. And so I think the goal there would be, again, mental health. Adding more medications for mental health is needed. And I'm actually not sure. I don't think I would add testosterone, because I think that in itself would cause such dysphoria to them. But I wonder if Dr. Folsom has any suggestions if someone's having dysphoria post-orchidectomy or orchiectomy.
So what is the specific question?
So a trans woman patient that has a gender-affirming removal of genitalia, if they have, kind of from the drop in testosterone level, if they have kind of a trigger of their dysphoria, how to manage that.
Oh, so a transgender woman
Mm-hmm.
who has a gonadectomy and or vaginoplasty.
Mm-hmm.
I mean, typically dysphoria gets better because they have the body part that was causing the dysphoria removed. We know that many people don't desire gender-affirming surgery, including either a vulvoplasty or a vaginoplasty. They're happy with that part of their body, but if they have such significant dysphoria that it has led them to pursue surgery, typically the dysphoria gets better. If we're talking about hormonal effects of testosterone, I mean, typically they're on enough hormone suppression that their testosterone level is going to be pretty low before the surgery anyways. So I have not seen that dysphoria worsens after surgery, and I haven't seen any unusual hormone related or effects that I think might be related to that decreased testosterone production, since it's already suppressed anyways typically. I will say though that for people who, for trans men who undergo a hysterectomy and an oophorectomy, I have seen quite a few people experience pretty significant hot flashes, similar to women who have had a surgical menopause. And it seems to be triggered by a really high increase in FSH after surgery. So even though the ovaries, we think that they're suppressed on testosterone because the estradiol level is low, I see a big surge in FSH, and I've found that a little bit of progesterone can help to manage the hot flash symptoms after an oophorectomy.
Very helpful. Thank you so much. Any other questions? All right. Well, thank you.
Thank you very much.
Have a great rest of the day.